The trial I'm going to speak about today is Atezolizumab in first line. This trial was a phase 3 study, and it had three arms, which was very unique. Which was standard of care was carboplatin, paclitaxel, and bevacizumab in a patients who are stage 4 non-squamous thing. The two arms were used. Arm A had replaced bevacizumab and atezolizumab, carboplatin, and paclitaxel, followed by atezolizumab maintenance, and all 4 drugs, ECP plus Bev. Question was, can we add and get a benefit, or can bevacizumab completely replace by atezolizumab? So with this, they were started. There were two co-primary endpoints, one is PFS and OFS. This is a new trend where we're seeing two primary endpoints. So there was a statistically significant benefit in adding atezolizumab in this arm. The comparison arm from B, which is 4 drugs versus standard of care, definitely there was a median survival benefit was there. Almost 40% of patients had 2-year survival, and there was a meaningful survival of 4.5 months in a subset of first line setting. What was interesting was the response rates were very much higher compared to 2 arms in all the possible PD-L1 expression. One thing to notice, even on PD-L negative expression, there was more than 50% response rate was expected. So, PD-L1 patient had the highest benefit from this combination. So what is being quoted and what is being advised or discussed a lot of thing is, in EGFR and ALK positive patients, which formed almost 10%, like out of 1200 patients, 160 patients were the other mutations, and sensitizing mutations were almost 91 patients, and they had prior therapy in almost 80% of the patients. So these patients had initially curve, as we expected, was almost overlapping. And after 6 months, it started separating out. And there is a plateauing of the curve at the end of the tail. But this had a difference in the survival when we compare arm B versus C. And in sensitizing mutation also, we expected the OS benefit. And what was seen is arm A, where the atezolizumab replaces the bevacizumab versus just bevacizumab. There's not a much significance. So adding immunotherapy as a replacement for bevacizumab in this subset of patients is not worthwhile. And there is definitely improvement in the overall response rates, and there are almost CR rates of 6% in the 4 drug regime. And subsets like liver mets, where we fail to get an optimal survival, there is clear-cut separation of the lines. There is arm B, that is the 4 drug arm was better than the 3 standard of care. And in the patients, when you compare the other arm, that is just arm A and versus C, there was no benefit. So definitely the 4 drugs works better in the liver metastasis, where atezolizumab is added to the standard of care. So the safety profile was very much comparable, but definitely 4 drugs had its own side effects, and there is no exaggeration of immune-related side effects when you use the drugs. So with this, it met a endpoint, and I think it may be the only trial where we have so many drugs to give in the all-comers. Benefit is seen across the subset. I mean, there is caveats for it, whether we can extrapolate it to the EGFR positive patients. But as of now, this is the only study where it is looked so closely. And definitely, I think it's well tolerated and can be considered. That finishes my slide. And any questions, I'd be happy to take it.